Welcome to In Session, the North Carolina Healthcare Association's podcast where we dive deep into critical issues impacting hospitals, patients, and the overall health of our communities. Whether you're a legislator, policy advisor, or community leader, this series is designed to keep you informed about the challenges and opportunities in healthcare today.
Welcome to In Session. I'm James Tucker, NCHA's Interim Vice President for Government Relations and Legislative Counsel. Glad to have you join us today. We're going to get into a couple of issues that are high priorities, among the highest priorities for us at the association heading into the short session. I'm joined today by my co-host, Anthony Okunak, Vice President of Finance and Financial Policy here at NCHA. Welcome, Anthony.
Thanks, James. Happy to be here.
Let's get back into these highest priorities, Anthony. I think I'm going to start first with the Medicaid rebase. Now, as we understand, every year we go through a process of resetting this rebase, and this essentially is the ground level state funding for our Medicaid program. And for us in North Carolina, this is particularly important because we are among the expansion states. We have a lot of different considerations, and we've been through a number of debates on how to set the rebase for this year and for years to come. And I want to get a sense from you how important it is to have those annual conversations. And from our perspective, why hospitals are really attuned to what's going on in Raleigh around the rebase.
Thanks, James. I would say just as, a constituent, as the state of, North Carolina in general and policymakers listening to this, obviously rebase discussions are really important because Medicaid is, one of the largest items in the North Carolina budget. It's a significant amount of money paid by constituents. And so, the General Assembly has a big job at, managing those costs. And like every other industry in the nation right now, prices are rising. We've seen inflation, input costs is increasing, and so healthcare costs is increasing, and so is the rebase ask year over year. So, it's really important to fund the rebase, obviously keep the Medicaid program going, but at the same time, policymakers do have an obligation to look into the cost of the Medicaid program and, determine why it's rising and how can we bend the cost curve. So I would say for North Carolina hospitals specifically, James, why it's important is because, NCHA members, providers, specifically hospitals, treat Medicaid patients. They have their doors open. They're willing to provide care to these patients. So, ensuring that patients are covered and claims are paid are obviously a big thing to the operation of hospitals. So it's really important to follow this rebase discussion.
Thanks, Anthony. I'll take us back a few months just for some additional grounding. Is in the fall of 2025, there were some disagreements about how to move forward with rebase funding around the total, what was needed. I think you're right. There was some analysis done, and we learned firsthand from the hospital community what it's like to go through that and to see how that may play out as we saw proposed and the implementation of provider cuts in the short term to help stretch dollars that the department wasn't sure was going to be in place to continue funding. And we seem to be in a better place heading into short session, at least an agreement on a number, but certainly when we want to avoid those outcomes longer term. And I've also heard that if we're not focusing on the rebase, we're not focusing on Medicaid early on in short session, the program may run out of general funds by middle of May. So if that were to happen, just think about what that would mean for hospitals and the Medicaid population in North Carolina.
That'd be a big deal. I know when there was discussions about the rebase not getting funded previously and those, provider rates were enacted, there was a proposed 10% cut to hospitals, which would have equaled about $720 million loss to hospitals across the state, which is obviously a big deal and really hurts hospitals in their budgets. And they have to have discussions about, how do they prepare their budgets for something like that? And, is there any potential cuts to services, which, we never want to hear, but sometimes does occur, as we have seen, especially in smaller rural areas that just don't have the operating margins to handle cuts like that. So, obviously that is a big deal, but to your point, I think we are well beyond that. And, hopefully the discussions are going well in regards to fully funding the rebase here in North Carolina. I think, since you bring up provider cuts, James, I think one thing we should probably talk talk about is just, bending that cost curve and what do we do in a future situation, because, the rebase discussions will continue to occur, right? We're going to, this is not just a one-time thing. We're funding Medicaid in the future. So what are your thoughts on that? I have a couple, but I'll kick it to you first.
Thanks, Anthony. I agree. And this conversation is playing out at the legislature as well, and thinking beyond just the current fiscal year and where we need to think about how to bend that cost curve and to be as good of stewards as we can with these state dollars and also with federal money that's coming in around the program, and how to be more efficient. So I know those are conversations that we are having with the legislature, we're having with stakeholders to determine a good path forward, and they've been productive, but certainly they're going to continue. And it's good to have all stakeholders and those impacted at the table to talk about that in ways that are helpful. How about you?
Yeah, I think that's well said. My big thing is, which I'm sure you believe, James, and I know our CEO, Josh Dobson, would say, like, we are open, to have conversations with policymakers and individuals at the General Assembly on how to bend the cost curve and see, what we can do to help, specifically what our members can do to help. But we just want to make sure that, anything in terms of bending the cost curve is handled through actual care management in getting patients timely care in the proper care setting, and, not seeing a reduction in Medicaid expenditures by, arbitrary rate cuts or inappropriate denials, right? Want to make sure that, in North Carolina, since we are in a managed care environment, that is our payment program here, which means, we have the managed care organizations, the standard plans, the tailored plans, insurance companies essentially handling the care management and the claims processing for our Medicaid beneficiaries. They should really be stepping up to ensure they're driving down costs through proper care management instead of any arbitrary provider cuts. So, I really just want to make it clear that the door's open for NCHA to have conversations, on proper care management, but just want to make sure that, anything we get into going into this session doesn't really come into arbitrary cuts that can really hurt providers who are already on thin margins. So what's your thoughts on that, James?
I think that's really well said and a great suggestion. And I want to come back to the thin margins and the rural impact in just a few minutes. And I know I agree. One of the worst outcomes of the debates, and they are very necessary for long-term stability, is to rush any decision-making and to not account for what would be the patient side, the patient impact of any arbitrary changes. We don't use the word arbitrary loosely or glibly. We're very concerned about what may be proposed or considered without a broader conversation. And I think Anthony's right. The hospitals are ready to be a meaningful partner as part of those, and look forward to that.
Why we say that, how it's not lightly, is especially in Medicaid, right? If you're doing a cut, you go out there and you read, you can almost see any source that Medicaid pays between, 70 to 85% of the cost to provide the care. So there's already a deficit in Medicaid most of the time to provide those services for a provider. And so any additional cut on that just makes it worse. And what you don't want to see is, network adequacy issues where you don't have enough providers in the system to give the care because they're not getting the reimbursement. So they end up just not seeing the Medicaid patients. And when, to your point, you just brought up rural healthcare, when rural healthcare is already severely understaffed, right? Do you really want to make it, that much worse in those specific areas? So I think it was, well said on your part that, we're just not throwing out that word arbitrary for the fun of it. I think, there's real impacts to communities when you slash rates. And so I think it's a collective effort to come to the table because healthcare is complicated. And I think if, there was a solution to bend the cost curve that was a one size fit all, then we'd be doing it. But I think, across the nation, we're all trying to figure this out.
No, thanks. I think that's a great point to raise, and actually leads in better to the next topic I want to discuss with you for a couple of minutes around the impacts of the One Big Beautiful Bill Act we saw at the federal level. You and I worked on this very closely last year with our delegation. I think when it comes to the one-size-fits-all approach, that was certainly better characteristic of the federal approach, in my opinion. Any number of issues I think we'll talk about as we get through session, but one thing I want to broach with you today is around the Medicaid work requirements, which are going to be in effect by January 1, 2027 for every state in the United States with an expansion population. These work requirements, just very quickly, high level, are 80 hours a month of work, volunteer, education, or other related approved activities. These are for all adults, all able-bodied adults between the ages of 19 and 64 in the Medicaid population. So essentially Medicaid, the Medicaid expansion population. There are some exceptions that are in law and that states will have the ability to craft a little bit, to tailor more to their populations in some ways. These include women who are pregnant, some postpartum, the disabled, the medically frail, which has a broader definition, students and parents and caregivers of children under the age 14 or have dependents who are considered disabled. So there's some exceptions there, but this is more of a broad requirement. Now, because this is the expansion population, this really targets expansion, I want to get a sense from you why we are very focused or why we are paying very close attention to how this is working and being implemented in North Carolina.
It's twofold, right? Obviously, as I stated, pretty much all North Carolina hospitals provide care to the Medicaid population. So, getting an understanding of how these work requirements will be implemented, potentially how people will be disenrolled and lose healthcare coverage is, one big factor and why it's a big deal in North Carolina that we'll be monitoring. And then the second will be in, North Carolina, hospitals fully fund the state share of expansion. So in North Carolina, expansion is fully funded between hospitals and the federal government. So it's a 90-10 split. 90% of the funding comes from the federal government. And then the additional 10% state share is actually not paid by our state or the general fund or, by taxing constituents. It is by a tax on North Carolina hospitals. So any increased costs to implement these work requirements will obviously need to be monitored in North Carolina to see how it's funded.
Thanks, Anthony. And I know we are in close conversations with our partners and those that work closely on this, the General Assembly and certainly the department to try to find a solution that will reflect, I think, the broader fiscal challenges facing hospitals with respect to what the One Big Beautiful Bill Act has implemented more broadly in Medicaid. And again, we'll be talking about that more in future podcasts. But also, I think to your point, ensuring that whatever we do protects patients, ensures that access remains for those in that population as much as we can. Do you think that's fair to say?
Oh, yeah. I think that's fair to say. I think the other thing that's fair to say is, our members and the association wants to partner with whoever to make sure that, one, we're obviously adhering to the federal guidelines on work requirements, but two, we are also reducing the administrative burden of these work requirements the best we can on our counties and ensuring that, patients, are not bogged down in paperwork and are able to get the information they need to the county and the state to make sure they, maintain healthcare coverage if they're meeting their hourly obligations. So just want to make sure that we are not inappropriately kicking anybody off of Medicaid, because obviously anybody losing their healthcare coverage who deserves to have it is meeting the requirements would be detrimental to that individual. So however we can help and reduce administrative burdens, James, as you're aware, hospitals are obviously a frontline contact with these patients. I know our members will have to, with their patient financial service teams, ensure that anybody accessing the hospitals, is getting to their DSS offices and properly enrolling in Medicaid and providing the paperwork they need to show that they're meeting any work requirement obligations. So there'll be lots to come. And I think, that's another thing we'll have to partner with the department on, the Department of Medicaid, and also the MCOs in North Carolina and the county offices.
Thanks, Anthony. And those are great points, especially around the administrative burden. I think we've had discussions, I know our members have, and you said it very well. The last thing we want is for those who are eligible, meet requirements, and have every right and reason to be part of the Medicaid program to lose out or have issues because of paperwork delays or any issues in processing, and whatever we can do as hospitals to help do that as part of our obligation around the expansion population. I think we're committed to doing that. I want to go back to a point you made earlier on the rural impact on the bigger concern in North Carolina. Has the second largest rural population in the whole country, only second to Texas. So rural healthcare really is North Carolina across the state. So I think you articulated about thin margins. We talked a little bit about some of the special concerns around there. When you take into account, how we have to be appropriate stewards of the rebase money and also recognizing some changes that are coming at the federal level, where do you think some other challenges may exist for our community hospitals, for our rural populations? What else should we be watching out for and monitoring and trying to work with our policymakers to help address?
That's a great question. Specifically, what I deal with, I think, what we've seen with some of the cuts in HR 1 to providers, specifically hospitals, I think is going to be a big deal. As you noted, it's going to be a way bigger of an impact for our rural hospitals. I mean, they are obviously running into the hurdles they always do, right? There's fewer providers in the rural areas. It's harder to establish those pipelines in the rural areas to recruit and then to maintain either, providers or nurses. You run into distance problems and transportation issues. And then, with the financial problems, I think some of it just has to come down to economies of scale, right? You have less population that you are spreading your fixed costs to. So that's always a problem in rural North Carolina, regardless if it's healthcare or not. It's any sector when you are spreading your fixed costs among a smaller population, it's going to be harder to manage that. So usually because of social factors, you can have a sicker population in rural areas. And so I think in North Carolina, as you said, being the second largest rural population state, we have a big hurdle and challenge ahead of us in the coming years as we look down the road for healthcare.
Thank you, Anthony.
I appreciate the time, James, and appreciate, anybody who's listening. I know you do too, and I know our members do, and everybody at the association appreciates any policy individual listening to this. But, what I will add is that we're always open to the conversation. We want to have a seat at the table to discuss because healthcare is complicated. We've talked about just a couple topics today, but James, there's so much more. And even on the topics we did discuss, I mean, rural healthcare in itself can be discussed at length, and there's a lot more complications than what we just even hit on. So just want to thank you for the time and, say, which I know is we're always willing to discuss with policymakers.
Well, that has been the case throughout this conversation, Anthony. Very well said. Thank you for your time this afternoon. And again, you're right. We touched on a spec of a couple of priorities for the association, for the people of North Carolina, for our Medicaid population. More to come on all of it. Again, appreciate your time and the conversation. Good chance to talk about work requirements, to talk through the rebase a little bit, and get into rural healthcare, just a very small portion, very small slice of the broader rural healthcare conversation we look forward to having with you, with others in the association as in session proceeds throughout this short session period. So again, thanks everyone for joining. Please stay connected. Follow us on X at NCHA GovRel, and that is NCHA GOVREL for our advocacy updates, and sign up for our weekly advocacy newsletter at ncha.org. Thanks for listening.